I'm introduced. Good evening, everyone. We might as well go ahead. As usual, please sign in. I think you know why at this point. And thank you to MCAT for filming this as all. Has anyone had a chance to look at any of the MCAT presentations other than me? If you have missed a lecture and need to use it for your paper, you can get some of the lectures that way. Okay, the speaker who was scheduled for tonight is not here. He called this morning and said he was up all night sick. So I'm going to give the presentation tonight, and I'm using a presentation that I made for another situation on the global HIV epidemic and some of the work I did as part of that. So I'm going to start with a brief YouTube video for 10 minutes, and it's a video developed by a nonprofit organization called the Elizabeth Glazer Pediatric AIDS Foundation, who I worked for 7 years. And I had two different jobs when I worked for them. One was basically I directed their activities in Rwanda, and then I also, for 2 years, and then I worked for them and lived in Mozambique and directed their activities in Mozambique. So the video at the beginning is it's sort of, they're bragging a lot about the success of a project that they had. And the project was they got 8 years of, hundreds of millions of dollars from CDC to scale up HIV treatment services in Africa. And this was a video they made at the end of their funding. And it's a really, apart from the bragging, it's a really well done video. So I'll start with that, and then I'll give a presentation afterwards.
Today, on the continent of Africa, nearly 30 million people have the AIDS virus, including 3 million children under the age 15.
I don't think we knew what hit us. I had one doctor say to me, it's like looking into the face of a dragon. We had patients just shrinking in front of your eyes.
People in the prime of their life, and they're not supposed to die, or small children.
One word defines it. There was death everywhere.
There was a hopelessness amongst our staff and a sense of bewilderment in the community. What is this thing that's hit us?
We had no ARVs, and there was nothing I could do.
To meet a severe and urgent crisis abroad, tonight I propose the emergency plan for AIDS relief. I ask the Congress to commit $15 billion over the next 5 years to turn the tide against AIDS in the most afflicted nations of Africa and the Caribbean.
Been involved in Mozambique, South Africa, Zambia, Cote d'Ivoire, and Tanzania. In those 5 countries, it's been one of the lead programs that have helped the country roll out treatment, care, and prevention.
It was a very bold statement to put a lot of money behind it and really make a very big push. A lot of the other projects before tend to be smaller scale, and here there was really no limit.
We thought we probably could get about 35,000 people onto AIDS drugs. Back then, it was the best news ever.
path through Project Heart, their accomplishments are almost epic. They have placed about 550,000 people on life-saving antiretroviral therapy. They've counseled and tested about 2.5 million pregnant women, and they've provided care and support for about 1 million patients at over 500 ART sites and over 1,000 PMT-CT sites.
That was a boom in the number of people that could access treatment, and that made a huge difference.
It was a kind of miracle. We saw a patient about to die survive and get better and return to job.
Now we can tell them with hope that if you follow instructions, the treatment, that you can improve your health and also even prolong, extend your life.
Children were always lagging behind, and that was painful. They are the most innocent victims of all these pandemics, and they should have the priority.
Just through Project Heart, they've initiated therapy for about 50,000 children, which is extremely difficult in these kind of situations. It's difficult to take the medicine and take it right and take it on time and take it every day. It's difficult for adults. For children in these kind of settings, it's really, really challenging.
There has been a lot of effort to provide early infant diagnosis because we know that children become sick much more quickly than adults, so we want to be able to identify these children as soon as possible and get them onto life-saving treatment.
When a mother finds out that her baby is negative, it's such a blessing, it's such a rewarding time.
When I'm negative.
That was phenomenal, that you could give a child a gift of an HIV-free life.
Preventing the infection to the baby is great news. It's not going to help the baby to not get infected if the parents die.
We took care of the mother, but we forgot the father. Now we are striving to implement a vibrant family-centered care.
Now the family is treated under the same roof on the same day, and that helps quite a lot.
Many times there is no there for a health system. It may be a clinic with one overworked nurse doing everything, serving many thousands of people. So that system needed to be improved upon.
During the past 6 years, we put in place the foundation. The foundation is skilled care providers. The foundation is laboratories that we equip. The foundation is the improvement of the physical infrastructure.
We really worked within the existing system. We didn't set up separate clinics. That was hard in the beginning, but it has paid off in all those years because now indeed we can leave the districts and the hospitals, continue with the services without us having to be there.
The story's been started with Project Heart. It's not over with, though.
The number of new infections per year still remains in the millions. That's our next quest, is to try to significantly decrease that. In fact, decrease that by 50% or more.
It's not in anybody's interests to stop doing this. It's not in the donor's interests, and it's certainly not in the interests of national government, political leaders, community leaders, and least of all, families and kids.
Project Heart has been a life-saving program.
Currently, about 10% of all the Africans on ART are through programs initiated by Project Heart. Just an unimaginable goal and accomplishment. It's been a real privilege to be able to do this.
From the bottom of my heart, I want to say thank you to the American people.
Thank you, Project Heart.
Thank you to the Project Heart program and to PEPFAR.
Thank you, Project Heart.
I have no doubt that many of our children wouldn't be alive today without you guys. And I just want to say thank you. I really have seen miracles here in this place.
That program was finished. CDC kept funding a lot of those activities, and some of those activities have been transitioned to host country governments and or local organizations. And I'll even get to a little of that here. Any other questions about that video? Sorry, it's a little dated. I think that was made in 2012 or something like that. So, and the numbers have only gotten bigger. Presentation.
So Project Heart is a subsidiary of PEPFAR. PEPFAR funds Project Heart.
PEPFAR funded Project Heart. Project Heart is over. And the implementer of Project Heart was the Elizabeth Glazer Pediatric AIDS Foundation. So I'm going to talk a bit about the global AIDS epidemic and then the impressive role that the US government has had in combating HIV here. So I'll briefly go over the history of HIV/AIDS because it's a recent epidemic, and what the global response to the epidemic has been, where we are currently, and the future. But I will say even the future is now from a couple years ago because I didn't have time to work on this today. So I think it's important to realize that the history of HIV in the US or in first world countries is very different than the history of HIV in developing countries, particularly sub-Saharan Africa. So in the US, we never heard of AIDS or knew anything about AIDS until the early 1980s. I was in my medical training then, and I remember this mystery illness that gays and Haitians and hemophiliacs got, and it was a few years before it actually got a name, and then a few more years before there was a way to test it, and then probably, I think, it wasn't until the mid-90s when there became effective treatment for HIV, and up until that point it was this feared death sentence. Everybody was petrified of it. But then in the 1990s, there was the development of what we call ART, that stands for antiretroviral therapy. And HIV is a retrovirus, so it's anti this type of virus. And it's a combination of drugs. And then there was also the development of something called PMTCT, which is actually prevention of mother-to-child transmission of HIV, because HIV passes through the placenta into newborns and also in breast milk and can infect newborns. So babies can be born with it, and if babies are born with it, the majority of them die before their second birthday. But with the scale up, because we have an intact medical system and insurance and can afford these drugs, really within a decade, the HIV epidemic plateaued and became under control within first world countries. And that was not the case in Africa. Now there are still 50,000 new infections a year in the US. Most of them are in high-risk groups who engage in risky behavior. And I'm not going to focus on that because that's actually not the history of AIDS in Africa. In Africa, That's where HIV originated. It probably was a mutated virus from a chimpanzee. The latest theory I heard was in Cameroon in 1930. And it smoldered there for 50, 60 years, gradually spreading in many countries throughout the continent. It didn't become recognized until after it had spread to the US and the test was developed, and then we were able to find out it actually is what is killing millions and millions of Africans. So it slowly spread around Africa, and it concentrated more in southern Africa, mainly because there's a net migration of men in Africa towards southern Africa to work in the large mines in South Africa. And a lot of the HIV infections exploded in the mines there, because you'd have thousands of men in close quarters all working in hard situations, and they spread the virus there. It's particularly easily spread in men who are not circumcised, and that's the custom in South Africa. And this is a map of the spread of Africa. In 1982, you can see that there was a low level of HIV infection already in most of Africa, most of sub-Saharan Africa, before we even recognized it in the US. And then it just advanced in a frightening fashion. By 1987, you can see there's 10 or 15 countries that have an infection rate of over 2, sometimes as high as 10, sometimes even higher, meaning that if it's 20%, 1 in 5 people in the country has HIV, and it was a death sentence. And you can see it kept expanding and moving and focusing in southern Africa, so that by the year 2000, and this program started in 2003, but by the year 2000, the majority of countries in sub-Saharan Africa had major epidemics out of control with HIV. And the impact, what did that do to Africa? It was devastating. Hospitals were overflowing and overwhelmed. I would have to walk over bodies, and everybody almost assumed 80% of the population there had HIV. The number of orphans tripled in Africa. School enrollments dropped. Struggling families who were already sick adopted other orphans and kids in the street. The number of abandoned and street children increased. The number of kids living in their own sort of little family nucleus increased. Women were forced into prostitution. The number of people with real jobs declined. This is in a country where people are desperate for jobs, or a continent where jobs are scarce, and they were declining. And life expectancy in Africa decreased nearly 20 years. That's huge when you look at the population. So HIV had and still has a devastating impact. We'll talk about this a bit. This is in Lesotho, a very hard hit country, but there was a new profession of coffin makers. And if you look at the global prevalence infection of HIV, you can see that Africa is the epicenter of the epidemic. It has spread globally, but Africa is still where it's hit here. And in 2012, we estimated there were some 30 million people living with HIV. I think that's now kind of flatlined. It's maybe in the high 30s, but it's not climbing the way it used to. Now, Africa already is a continent with many, many burdens. This is life expectancy, and you can see it's the continent with the lowest life expectancy. And even before HIV, it had the highest disease burden from malaria, from other diseases, and the weakest health system. It certainly has it has a critical shortage of health service providers. If you look here, look at the countries with critical shortage of healthcare providers, you see them in the developing world, but you see the worst in Africa. And if you look at the number of health workers per number of diseases, or the global disease burden, you can see that the developed world has the highest number of health workers per burden of disease, and the countries with a much greater disease burden have the lowest number of healthcare workers. So it's very disproportionate the way different parts of the globe are affected by HIV. And health workers are necessary to save lives. If you don't have nurses to help deliver babies. You will lose mothers, you will lose children. And this is just basically a graph that shows the more health workers you have, the probability of survival is directly related. So if you don't have health workers, how are you going to treat diseases? So this is sort of the face of the epidemic in Africa. It is women and children by and large. HIV biologically is spread in certain ways. It's spread by blood, through the placenta, breast milk, penile, and vaginal secretions. And therefore, it's spread with certain practices or certain groups of population. Men who have sex with men because the rectum doesn't have very good defenses and is easily torn, so viruses can pass through the rectal mucosa quite easily. Migrant men were key transmitters or propagators of the epidemic because they took it from one geographic locale and took it to another geographic locale. So you could actually see the epidemic spread along transportation routes, on truck routes, things like that. Now, migrant men spread the disease, but then it spread to women who are more easily infected than men through, if you have a man and a woman having sex and the woman has HIV, the man is not nearly as likely to get it as the reverse. If it's a woman and man having sex and the man's infected, the woman will get more infected. The HIV virus is retained under redundant skin in uncircumcised men. So that area is a reservoir of HIV. Sexual violence, where there's likely to be tears in skin or in the vagina, is a high likely way to spread HIV. Mothers will spread it to babies, intravenous drug users. Adolescent girls are a group that are the fastest growing population with HIV. And that has a lot to do, not because they're promiscuous, but because they often have sex to survive. In Africa, people are hungry, they have children to raise, and there's a lot of cross-generational sex where older men have young girlfriends and they get infected a lot. So young adolescent girls are the fastest growing population with HIV in Africa. And in general, in poor countries, women are usually more vulnerable. And so they are the victims often in what we call transactional sex, not really professional sex workers, but women having sex to get a meal. And what happened? Basically, in the 1990s, as we said, in the first world, there was a cure for HIV, and basically the epidemic really turned around. But that didn't happen in Africa because they don't have healthcare systems and they didn't think there was money to treat the epidemic. But in 2003, in 2001, WHO and the UN and then other countries said this is morally unacceptable to have a whole continent of people dying, especially a continent so poor that they can't manage the HIV response. So let's make a global commitment to treat Africans with HIV. And it has been the largest public health effort in terms of total funding ever in the history of the world, this effort to treat HIV. So the amount of money going in there is enormous. And the USA funded this program, PEPFAR, President's Emergency Plan for AIDS Relief, in 2003. And I started working for that program in 2003 and continued for about 10 years. And George Bush, I give him credit for this. Initially, I will say it had sort of an abstinence and an anti-prostitution focus, but it very much morphed into what's the evidence, what does the data show, what are the best prevention techniques, and I think it is an amazing program still. And they worked primarily through international NGOs because this was felt to be an emergency. What are the organizations with the capacity to get there quickly and start saving lives? So it was not about building capacity of African organizations at all in the early years. It did go that direction a bit. It's still not there the way I'd like to see it, but It was a lot of work close with local healthcare systems. Foreigners didn't arrive there and set up their own clinics. That would not have been smart by any reasonable way to work. So it was working very much with African healthcare systems. The countries in red are the countries that the US government focused on. Basically, all of them were in Africa except for Guyana, Haiti, and Vietnam. ART is antiretroviral therapy, just some basics on it. It's a combination of 3 drugs. It suppresses, it does not eradicate the virus. Therefore, it requires lifelong treatment. So it's not like a cure. You don't get rid of the disease. You have it for life, and you have to stay on the medication for life. And if this program stopped, all those people whose lives were saved would die. So it's not a program that's going to end soon. You have to take it carefully and follow instructions, or otherwise you can develop resistance to the virus. So it's not like a vaccine where it's a one-off intervention. It's a lifelong treatment where people have to go in every month and collect their medication and make sure they're responding to it. So it's not an easy disease to treat. But there, you can see this enormous scale up in the number of people on medication, and right now in 2015 it is close to 15 million people in Africa that the US government is helping stay on this treatment. And how did the treatment change? Because in the US or in first world countries, you've got lots of doctors, you've got lots of labs, you can do all this. You couldn't do that in Africa. You didn't have the doctors or the nurses or the facilities. You didn't have the roads or the electricity or the water or a whole lot of things that is how we actually did it in the United States. So there were quite a lot of ways that it was adapted for low-income settings. First of all, the WHO played a critical role in establishing global treatment guidelines. In the US or Europe, there's all sorts of drug combinations. Here they tried to very much simplify it to something that could be scaled up enormously. And so there were standard treatment guidelines that all the countries pretty much, I mean, they adapted to their own uses, but by and large followed global guidelines. And at the beginning, sickest patients had priority because you couldn't treat everyone. So if you had, one nurse who was trained in ART, how did she decide who could get the treatment? So initially it was the sickest first, but basically the science today shows that anyone who's got HIV should start treatment as soon as possible. And so as capacity has been built, more and more people are on it. There's been prioritization. Now all pregnant HIV positive women get started on it for life because to avoid passing it to their baby. And then we started in the big specialty hospitals in the urban centers because they had the greatest capacity. But this is an epidemic that goes on in small towns and small villages and rural areas. So it's been decentralized really to some of the most rudimentary health posts in many of the countries. And so how do you tell one nurse who's managing a whole clinic by herself and might only have 30 patients who are HIV positive? How do you help that nurse manage a complicated disease in those conditions? Single line. Okay, yeah, basically there was a standard treatment regimen. If that fails, there's a secondary line of drugs, but by and large, in Africa, something like 96% of people get the same treatment regimen, whereas in first world countries, it's much lower than that. So initially, it was simplified protocols. We didn't do what's called a CD4 test. That's a test to see how bad your infection is. And many places didn't have access to that test, and so there were protocols about how to just initiate treatment. How do you evaluate patients? There's what we call task shifting to less skilled workers. We certainly work with programs now where community health workers manage this kind of treatment. They have to be trained, they have to be supported, they have to have written guidelines, they have to have a whole lot of support for them to be able to do it. But that's what's happened. And then we've looked at these very simple rural clinics that might just have family planning, prenatal care, and how do they start treating HIV positive patients in those settings? So there's been integration of HIV services into very simple settings. And besides all that, we had to renovate buildings, we had to put in water systems, electricity, internet, phones, medical equipment. So there was a massive infrastructure investment just to help these clinics be able to provide services. I remember working in hospitals that didn't have any running water or electricity, and you'd give these patients their pills and they'd go out to a little contaminated stream and take water from the stream to drink them. And I remember arguing with people at USAID Washington saying, you gotta fund electricity. We can't possibly treat patients in these situations. There's been an enormous amount of community education and mobilization, because like most countries, Africans were petrified of HIV, and it was much easier to blame the people infected with it for doing something wrong than to see it as a disease. So there was enormous community education and mobilization. There's been a lot of money spent on empowering women, because women actually do a whole lot of the work in Africa. They're certainly the bulk of the nurses. And young girls have to be able to resist sex with older men. And older men have to be trained not to force sex on women. So there was a lot of community work in how do you stop young girls from getting infected. A lot of things in health policy and health insurance, because even though this HIV program was funded by external sources by and large, you still need there were many situations where the costs of care were not covered, and so you have to help countries be able to finance their health services, whether it's prenatal care or other services, just to get to the patients with HIV. So there was a lot of creative financing. How do you take HIV funding and actually turn it into healthcare services in a way that motivates healthcare workers, comes out with high quality care? We trained millions of healthcare workers, but you still then, if you send them back to a dirty hospital with no running water and bad salary, how do you motivate them to actually, stay there and do high quality work? There was a lot of research and program implementation, what worked and what didn't work. There were community microfinance programs to support organizations of people living with HIV, because they needed to still be able to feed feed themselves and their kids. And so it doesn't make any sense to give them drugs, expensive drugs, if they don't have any food at home. As we noted, there were tons of orphans and vulnerable children infected with HIV and affected by HIV. So supporting a lot of these organizations for orphans. And then on top of all that, there was a lot of basic capacity building of ministries of health, of local NGOs, of healthcare service delivery managers, of journalists to do public education. So it was way more than your usual healthcare program. This is an organization of kids with HIV. And don't they look great? This is a hospital in Rwanda I worked at. This was the sterilization unit. Those were the conditions that we worked in. This is a busy clinic in Mozambique that we supported. It looks like chaos. It actually had over 10,000 patients on ART, this one clinic. Circumcising men. There's been a lot of effort to circumcise men because it reduces their infectiousness by over half. So circumcision is by and large a cultural issue rather than a medical issue often. It's, it's what happened to you, that's what you do to your kids kind of thing. So there's been an enormous effort to educate people that if you don't want to get HIV, real men get circumcised. What am I looking at here? Okay, so if you look at how many people this program reached, so if you look at all the people who are HIV positive in sub-Saharan Africa, this 51% of people with HIV actually knew they were infected. So it's still got a long ways to go. This is in 2012. So barely half of the people with HIV know they have HIV. And of those people who have HIV, 32%, of 32% are receiving treatment. And then 24% of all the people with HIV actually have evidence that they're on the right dose and it's effectively suppressing the virus. So there's a long way to go still. But Some of the interesting things that happened, you may or may not remember that when ARVs first came out, their prices were enormous. And even still in the US, somebody who's HIV positive who's getting ARV will spend close to $20,000 a year just on the drugs themselves. So we pay enormously inflated prices for these medications in the US. But you can see how the price of drugs fell in Africa. And there were quite a few reasons, but basically demand went up because governments were now paying for drugs, and a lot of drugs started being manufactured in middle-income countries such as India, one of the largest producers, but there's also countries in Africa that now manufacture drugs. And then the WHO set up a qualifying system so that any drugs that were produced in countries had to be evaluated for the quality of the actual chemicals within the prescription. So if the WHO qualified you, then the US government, actually, we had to go to the top of the FDA to get approval to buy non-American made drugs. So for this program, just to get the price down under $100 for a year's worth of treatment, we bought drugs from all sorts of drug manufacturers as long as they met quality control. And you can see this is the average adult life expectancy in rural South Africa. Went down when the epidemic was at its worst and now has started coming back up. So it was one of the most meaningful things where you could see impact right away. This hospital, this is a brand new hospital, and look at all the people sitting on the floor in northern Mozambique that we help support. And you can also, other signs of success, you can look and see what sex workers are obviously one of the key transmitting populations of HIV. And so we followed what the HIV prevalence was in this population. And you can see that all the interventions, the prevalence of HIV in sex workers is coming down. And South Africa is the country with the most HIV-infected people in the world. It's where the highest concentration is. It's not, actually there's two small countries, Lesotho and Swaziland, that are right next to South Africa, and they actually have a higher prevalence rate. But South Africa is a big country with a population of 70 million people, I think, and it had about 25% of its population was positive. So it had more HIV positive people than any other country in the world, and it's also a middle-income country or upper-income country. So it had the money, didn't have the political will for a long time, but it had the money to actually massively test the entire population. So they have tested, this is where they've really got the most sophisticated HIV program in the world, I would say. So they massively tested the whole population, and they dramatically scaled up ART. These numbers are from some years ago, but every facility in the country initiates ART. The main killer of people with HIV is actually tuberculosis because they have no immune system and they get infected. But they were just massively giving out condoms, female condoms, circumcision. So it's the country with the biggest HIV program in the world. And this is how it was financed, because this all cost a fair amount of money. So it started out at a few $1 billion a year, and now it's steadied off at about $19 billion a year. And the U.S. is the biggest donor of that. We don't spend $19 billion a year. I think we spend about $12 billion a year. That is a lot of money, but it's a couple days of our war in Afghanistan or Iraq. It's so decide. I don't know. I won't get on a rant here, but I won't get on too much of a rant. But it's actually, it saves money to treat now than to let this epidemic run out of control. And here's a question I think you were asking earlier. Can African countries, how long is the US going to keep paying for this, and are first world countries going to keep paying for this? And what this shows here, the red line, these are the African countries that have the HIV epidemic, and on the left are ones that have the mildest infection, where the prevalence is lowest. On the right are the most severely affected countries. The red line is the amount, that the government, the host country government, the African country is paying itself for HIV. And the blue is the amount of money they're spending on health compared to their total health budget. So that's confusing. Let's just look at the red lines. But basically, on the right here, you can see that these countries are spending the bulk of their domestic budget on HIV in health. And quite honestly, these countries, well, the poorer ones of these countries are not going to be able to pay for this program until they develop more economically. And again, can African countries fund their own HIV response? What we're looking at here on the bottom is the prevalence rate. So over here are the countries with the worst infection, worst epidemic, and over here is what their own economic development is, what's their GDP. And the countries with the worst epidemic, some of them are middle-income countries. South Africa and Botswana are countries that have good economic development. Swaziland and Lesotho are middle-income countries. But over here you see the poorer countries. And you will see Mozambique, which is one of the higher prevalence infection countries, but is not economically developed at all. Zimbabwe. So these are the most afflicted countries. Rwanda actually is a success story, which we can talk about if you're interested. But it has basically, I won't say it's eliminated its HIV epidemic, but it's been remarkably successful. Okay, so what if we stop this program? Okay, the green line is what would happen if there wasn't ART, if we stopped funding for this treatment. And the blue line is if we kept covering the cost of it. So if we stopped paying for this drug, you would immediately, the success, the elimination of the epidemic would immediately go back up. So, and that would affect all of us. And the question is, can we continue? So we've gotten half the people with HIV have been tested. And what's it going to take to get the rest of the people tested and on treatment? And is it better to just sort of keep plugging away? Is it better to do a full court press now or just sort of do steady rate? Well, if you do the math, and economists did this, that actually it's much cheaper if you really scale up the services more quickly. If you take your time and just sort of do a steady increase, ultimately, okay, so this would be the fastest scale up, and this would be if you only treat people whose CD4 is under 200, whereas if you treat everyone with HIV, you will have a rapid decrease in the number of people infected, whereas if you only treat people who are more and more sick, it will ultimately cost a lot more, basically. Now, these scenarios where you treat everyone rapidly as possible have a much higher initial cost right up here, but the long-term costs would scale off dramatically. And this is the programs to prevent transmission of HIV from the mother to the child. Again, the gray line is if we just maintain the current treatment, this would be number of new HIV infections. So if you just maintain the current treatment, there will still be 200,000 children a year getting infected. Whereas if you go to, if you scale it up to 90% or also put all those women who are HIV positive who want family planning on family planning, and you reduce overall the epidemic, you will have basically elimination of pediatric transmission of infecting children with HIV. And again, countries that have scaled up treatment faster have reduced the HIV incidence more significantly over the past decade. So countries which have moved very slowly, such as Nigeria and Angola, still have less than 40% covered and have a much higher percent of adults with infection, whereas those who have really moved ahead to scale up treatment have had remarkable success. Now, there's tremendous heterogeneity or variation in how countries are doing, and each of these different colors are different countries. So you can see that Rwanda here, this blue line, has been a success story. And Mozambique, the other country I worked in, has been significantly less of a success story, although there still has been a lot of progress. And I was just in Mozambique in January, and they have dramatically increased their numbers, and there's millions of people now on HIV treatment. So they've made progress. Behavior change has not been that important in slowing the epidemic, to be honest. And this was a very controversial issue. There were groups of people who didn't want to spend the money on drugs and wanted to spend it on counseling people to have less sex or use condoms. But in Europe, in the US, in Africa, people like to have sex. People don't like to wear condoms. I don't think behavior is that dramatically different in either place. And then at home, we still have a significant HIV problem in certain parts of our country and among certain populations. And District of Columbia is one of those places that has 3.2% HIV prevalence. That's pretty significant. It is concentrated among Black men and Hispanic men. So it's not an equal opportunity virus by any means. In the future, we really need to train healthcare workers in Africa and give them the tools and skills to manage this. They're going to need support financially in some of the countries. But if we don't do it, their life expectancy is going to go down. Their workforce is going to shrink. They're going to have less economic development. So it's not going to, I mean, I think if we were to just walk away from Africa and leave it to them, it would be a major disaster, far worse. So these are 3 nurses I worked with. Okay, so I think I beat this horse into the ground. The end of AIDS is not in sight yet, but we do know what's working, and we know how to get there. We need to continually scale up and availability of ART. We need to strengthen their health systems. We desperately need an AIDS vaccine, but there isn't one in short-term sight. So in the meantime, there is a lot of hope for Africa and the world. They have made enormous progress. So that's it. Thank you. And I'd be delighted to answer any questions. Yes, please.
So as people start to encourage male circumcision more, is there also an increase in female circumcision? I mean, I know that's a tough issue because that has a very messy cultural history in lots of these countries.
Well, I don't think there's any move towards female circumcision. There's genital mutilation. Is that what you're talking about?
Yeah, sorry.
I think that is a separate topic. I don't think they're related. Do you want to jump in? Yeah.
I agree. I think that female mutilation is really on the downswing, according to, I've been working in Africa too, and the people I've met with and talked with really feel that that's definitely on the downswing. My experience with circumcision was working with the Zulu community, and the original Zulu king, Shaka, would not allow circumcision because it took warriors out of the front lines, and then they weren't able to fight, and it was very tribal, and so for centuries, the Zulu men were not getting circumcised. Well, while I was working there, the current king, King Goodwill, decided that since WHO said it was a good idea and the country was dying, he would approve it. So all of a sudden, all the Zulu men wanted to get circumcised. So it was kind of interesting that they were just waiting for the cultural okay. You know, they heard the news that it would help with the health, but they were waiting for the cultural approval before they really had it. So that's improving. So.
Yeah, in fact, many of the circumcision places have, you know, long lines and
waiting lists.
Yeah. Any other questions? Yes, please.
Just to clarify, does the antiretroviral therapy medications that decrease the likelihood of transmission?
Very good point. Yeah, in fact, one of the developments that has occurred since I put this presentation together is now they're saying treatment is prevention, and it is. The moment you're on medication, your likelihood of infecting somebody drops dramatically. And if you're taking your drugs as you're supposed to, it's probably close to zero. Any other questions? Yes, please.
When you introduced the drugs, did you get any resistance from the people taking them or the people over there?
Yeah, there were a lot of people who, there was enormous stigma. People didn't want to come to the clinic. I mean, initially there were all sorts of myths and preconceptions about people with HIV, you know, you can get infected if you talk to them or whatever. So people didn't want anyone else to know they had HIV, and they certainly didn't want to go to the clinic and, you know, go to the HIV clinic where everybody knew that those people were infected. And there were lots of stories of people getting kicked out of homes and stuff like that. Was there resistance to the drugs? I don't think the drugs were the primary issue. It was just the stigma attached to being infected. Yes, please.
Are you seeing increase or viral resistance? Is that becoming a problem?
There is some viral resistance. There's not as much as, actually, because there's been like standard guidelines and not sort of people stopping and starting different treatments, there's been less resistance in Africa than in first world countries. Yeah, so it helps to have everybody on the same treatment regimen and to keep it simple. But yes, there is some resistance. I don't think it's a huge issue yet. No. Yes, please.
Why are the drugs so much more expensive here in the U.S.?
It has a lot to do with the power of the drug companies in this country and the fact that FDA doesn't allow us to import drugs from other countries if they're made here. So it has a lot to do with policy.
Do you see a lot of people using black market drugs? Has there been?
Well, I don't know. I don't treat here, so I actually don't know. But insurance pays the high prices here. We all pay for the high prices here, basically. Thank you all. Thanks very much.